hi everyone. I think it's past, so we can make a start. Thanks for joining this FCI webinar with BMJ Best Practice and Health Education on integrating best practice into EHR systems. We just have a bit of housekeeping up at the moment on the screen, which you can hopefully see. If you could just keep yourself muted throughout the presentations until the Q&A at the end, and then we can ask some questions. And please do use the chat function for any questions you might have throughout the presentation. You can also use hands up as well at the Q&A at the end. And this webinar is being recorded at the moment, and it'll be up on the YouTube channel and website afterwards. Just to let you. So I think that's all for the housekeeping. Nick Booth, the Honorary Treasurer at the Faculty, kindly chairing today. So Nick, I'll hand over to you.
Okay, well, thank you very much, Joe. And thanks to everybody for coming to this Faculty of Clinical Informatics webinar on BMJ Best Evidence. And we're fortunate in having Dr. Chris Wroe from the BMJ Knowledge Centre and Lucy Reid from Health Education England, who are going to talk to you about the availability of the BMJ Best Practice to all in England, I think. And I hope that we'll be able to finish the meeting with lots of questions. If you want to ask a question, please use the chat facility, and we'll collect those together and ask them at the end. And if there are any further questions after we've got through the chat facility, we'll open up the discussion to people to pose their own questions at the end. We'll do a short evaluation of the seminar at the end, so we'll leave an evaluation questionnaire from Joe. We'd be very grateful if you could fill this in. You can also do the webinar on the YouTube Faculty of Clinical Informatics website, and you can access that through the Faculty of Clinical Informatics website. So without further ado, to Lucy from Health Education England, who's going to give the first part of the presentation.
Thank you, Nick. So my name's Lucy Reid, and I am employed by Health Education England. I'm in the Library Knowledge Services Department at Health Education England. We are not a library ourselves, but we act as the stewards of NHS-funded library knowledge services across England. Just looking at the list of people who are joining, I didn't see anybody from outside England, but there are similar bodies to ours in Scotland, Wales, Northern Ireland. So I'm not saying anything that's particularly England focused, although this piece of work is about England. So some of you will wonder why Health Education England is involved in the delivery of BMJ Best Practice and why it comes to the library and knowledge services. So I want to give you a little bit of background. Joe, if you could. Oh, thank you. So like I said, our team is the stewards of NHS knowledge services across England. We do things like professional support and consultancy for these about 180 libraries across England, with national policy and strategy. So the picture in front at the moment is our current national strategy, Knowledge for Healthcare, which has the vision of making sure that all of our staff and learners and the public use the right knowledge and evidence at the right time in the right place, and so on, for making decisions about their own care. An important part of this is so we do we quality assure services, we development for our own workforce, but also for the wider workforce. So we have a couple of programs like our knowledge mobilisation framework and health literacy and digital literacy, are for members of the workforce to improve their skills as well. But delivering content and the infrastructure for accessing the content is a key part of the work that we do. If your eyes are really good and better than mine are after 6 months of looking at this tiny screen, you might notice that this strategy is end dated kind of about now, but a new one will come out and it covers very many similar themes. Next slide. Thank you. So our strategy has 12 guiding principles, and it feels a little bit boring to mention these, but they're really core to why we are doing this piece of work with BMJ to deliver best practice. We do work really collaboratively as a profession, so what is in our strategy, our guiding principles, are pretty much accepted by our wider workforce across the country. So there are about 1,200 librarians working in the NHS in different parts, mainly in secondary care trusts. Important to this conversation are particularly things around collective purchasing and equity of access and opportunity, pooling resources through federation, and being a little. One of the things that we're concerned about is obviously. Next slide, please. So I mentioned that a core part of our work is buying and the infrastructure through which the content is delivered. Buying BMJ Best Practice as a national package is an important part of our ambition to enable all staff and learners to make optimal use of knowledge and evidence at the point of need. We've, for a number of years, been buying what we call a collection of core national content, and this has been more traditionally library resources like bibliographic databases, for example Medline and Cinenar. We also buy e-journals and e-books for the system. But clinical decision support is slightly sideways step for us. Next slide, please. It definitely forms part of our ambition to make sure that staff and learners have access to the evidence where they need it. And all clinical decision support tools are providing this in one way or another. So you probably are aware there are 3 main products on the market. So there's BMJ Best Practice, but also Dynamed and UpToDate, and they all provide some of the functionality that we were looking for our staff and our learners. Chris will go into more detail, but they are frequently updated. They're summarised and synthesised packages of evidence, and we're feeling that our staff want more and more synthesised evidence to decision making slicker and more time efficient. They follow the clinical workflow through from diagnosis through to prognosis. Another thing that we love about them is that they tend to have really great quality assured patient information, and that's part of our health literacy strategy as well. Also, they are clinical decision support tools, but they are also important in educating the workforce. So, as you'll hear from Chris, there are specific educational resources and CPD resources in BMJ Best Practice, but just having access to clinical decision support topics, maybe ahead of a consultation or following up from a consultation, is an educational resource in itself. And to go back to the first point, having access to evidence at the point of need, it's really important for the workforce that we're accessing, and we'll see later that how important mobile access is for our workforce, but also electronic health integration is of growing importance. Next slide, please. So the next question is why we were so keen to buy a national product for the whole of England. And this is why I mentioned those guiding principles earlier. It is really important to us that we make best use of our relatively limited resources for the NHS. I national core content, but that's only maybe about a third of the spend that happens across England on digital knowledge resources. So about 2/3 of the spend is sitting at trust level, which is great. People are buying products, people are using products, evidence is getting applied in practice, which is brilliant. But we're through that sort of fragmentation, we're not making best use of the resources. So, for example, when a product is bought at a trust level, the trust members of staff get to access it. That's brilliant. But there are people outside of that who don't get it. For example, for the most part, people in primary care are only getting national content. We also carry out a regular of all of that local spending. And in our 2018 audit, we estimated that there was about £3 million spent at local level on clinical decision support tools, which is a lot of money. That's brilliant. But again, not everybody was getting access. So people in primary care weren't getting it. Some places had multiple tools, but other places had none at all. And it's also not particularly time efficient for our workforce to be going through 180 sets of procurement every year. So centralising that was a really important gain in terms of efficiencies across the system. So we went through a procurement process to move from local procurement or to buy a national product which would meet our needs nationally, and thinking particularly about a resource that would meet the UK specific needs. So something that really focused on UK specific guidance, includes British National Formulary. We were also looking for something that supported the multidisciplinary work and learners across different professions. So some resources speak more to very specialist practitioners. Others are much more generalist in their approach, and we were looking for something that met a wide spread of needs by being generalist and multidisciplinary. We something that reflects something about the delivery of care in the UK around the split between primary and secondary care and the movement of patients between those different settings. And obviously, BMJ Best Practice best fit because we went forward make that purchase. Next slide, please. So from April 2019, the whole NHS workforce in England has had access to BMJ Best Practice. And I'll say again, if you are from Wales and Scotland, you've had access to this for slightly longer. And we did an initial wave of marketing. We bought the shiny new thing, get using it and so on. And we worked with our network of libraries to promote that to end users. And that was great, but it was a bit of a slow burn. We weren't perhaps reaching all of the areas that we really wanted to reach. So particularly thinking about getting into primary care and so on. So from earlier this year, we've been working much more as in a partnership with BMJ to really meet these different markets. And part of that is why we're here today. So one of the groups of stakeholders that we really wanted to meet with was you guys, because we see electronic health record integration as sort of the holy grail for uptake and usage. So we are getting hit there. Next slide, please. and we're beginning to collect some really great feedback from users. So again, across the different professions, using the resource in different ways. Last slide. And we're beginning to see some real uptake across the country. So that's not a great set of numbers that I can see for myself because it's all too blurry for my poor eyesight, but usage is beginning to really take off. So we did some really concerted promotion in August around the new junior doctor rotation, and we saw as a result of that there was some really good uptake over that month and so on. So we are beginning to grow usage, and importantly for our efficiency targets, we are beginning to see the cost per use really go down I mean, that's a positive thing, so great. But we need to see more use, not only for our own KPIs, but also because usage will impact positively on patient care and clinical outcomes. It will also improve clinical workflows and people being able to work efficiently because they're going straight to the evidence and making the right choices up front. And it should improve the use of staff time because the right people are taking the right decisions and doing the right things at the right time because they've got access to information. And as I was saying, we really do electronic health record integration as such an important part of that. I hate to use the term, but we know that colleagues are increasingly time poor, so they don't have in a consultation to open the app or to go off to the website and find out the information it needs to be in their site when they're working in the patient record. So it's great to have this opportunity to talk to you, and at that point I will hand over to Chris, who will explain how that happens. Thank you.
Okay, thanks, Lucy. Switch over to my slides.
Is that showing up?
Yes.
Brilliant.
Great. Yeah, so hi, I'm Chris Wroe. I'm a health informatician in the BMJ and the Knowledge Centre, as Nick said. I guess health informatics covers a lot of different areas. My specialist interest is in clinical decision support and knowledge representation. So originally trained as a junior doctor and left to go into academic health informatics at Manchester University on CDS research and also medical terminology research. Spent some time in industry on EHR implementation and SNOMED-CT implementation. And for about the last 10 years, actually been working at the BMJ, supporting the health informatics aspects of the content that we publish. So I'm going to describe myself as a bit of a geeky medic. What I'll do first, we go on to the next slide. And for those that are not familiar with, it's quite strange, with BMJ Best Practice, just to give you an introduction to it before I then kind of go into the health informatics parts and the EHR integration parts. So it's a bit frightening when I first started putting these together that I can now say that it was a generation ago that I first started working on the wards. And then when you wanted to look up information, you kind of relied on whatever you could fit into your white coat pocket. So it was a BNF and whatever other pocket guides you chose. And I guess two things have changed since then for me, or two key aspects. Is the emergence of evidence-based medicine and things like the Cochrane collaboration and guideline development organizations like NICE. And the other thing is, I guess, the migration to the digital environment, taking away some of those physical constraints of books. So the fact that you don't have a size constraint and you can update things more regularly. I guess one thing that hasn't changed is us as humans. So we still want concise recommendations or information, and actually that might have got even more of a need to get this information, and that's where BMJ Best Practice kind of targets its self-concise point of care information to clinicians. So we go on to the next slide. So as Lucy said, it's funded Education in England, so it's free to all NHS staff in England. And this is our webpage where you can get more out how to access that as an individual, that HE funding. And if you go on to the next slide. So in case you haven't seen BMJ Best Practice, this is a current topic on COVID-19, which is obviously being updated regularly at the moment, and it provides recommendations about the management of the. And as Lucy was saying, the idea is to provide a very structured, concise view that models the clinical process. So you have recognizable sections like history and exam, investigations, differentials, treatment algorithms, and that's consistent across the topics. So if you go into a different condition, you'll get the same structure. We cover about 900 clinical condition topics, and some of those actually group several different conditions together, and about 130 assessment topics, which talk about the management and take you through the management of common signs and symptoms and abnormal test results. And at the high level, those are linked to SNOMED-CT, ICD-10 codes, and I'll talk a bit about the impact that has on integration and how that supports integration in a bit. We kind of structured approach right down into the content and provide where we can these clinical prioritized itemized lists of what you should do in particular situations. So for example, on the slide is our web version with the first investigations to order for COVID-19, and on the right hand side it's even more important on the mobile web app that we have to make sure that we have those itemized lists that you can scan through quickly on a constrained device. In this case, it's the treatment options for severe COVID-19. So go on to the next slide. Obviously, clinical practice isn't all about just following itemized lists, and where clinician does need to dig into more detail, we layer that information on and they can expand out that detail and provide some of the context around it. So our treatment options are tiered into sort of first line treatments and second line treatments and how they need to be combined. The drugs are coded so we can provide links direct into the equivalent part of the BNF, for example. We provide a commentary on the evidence if you want to get an update on what evidence is currently available, and we link out then to that evidence and also the guidelines. And this year we also added the ability to link out at a topic level to local guidelines if they have specific instructions, say for a local trust or a region. Okay, if you go to the next slide. One of the things we've also this year, which you can look at because we make it freely available for the COVID-19 topic, is also comorbidities. So see, multimorbidity as prevalence is increasing across the population, but a lot of CDS resources at the moment, including our single condition focused, and we got a lot of feedback that it's really a gap in people's sort of confidence in how to manage those comorbidities. So you can see on this COVID-19 topic that if the patient has something like diabetes, the clinician's prompted to that, and then an additional layer of contents added, which provides guidance on, in this example, if you're adding something like a corticosteroid, which will interact with the patient's diabetes, how you should manage that three-way interaction between the acute condition COVID-19, the patient's existing diabetes, and the corticosteroids which you're using to manage and improve the patient's prognosis for COVID-19. Okay, if we go on to the next slide. So that's how a quick overview, and I kind of skimmed through it very quickly around what best practice looks like. I guess the question is, how did we get to that design, and how do we make sure that clinicians still find it useful? And for that, we have kind of three different situations. One of them is during the design phase. So we take a user-centered approach, and we use user experience specialists inspired by digital app development, really, and digital product management. So they go out, mock-ups and prototypes into healthcare setting. We get clinical volunteers to run through clinical scenarios and really understand how they interact with the content. And we video those interactions, and we also get the clinicians to think aloud, so we understand what their thought process is as they're interacting with the content, and how it's performing in terms of answering their questions. Once the content's gone live, we use user analytics. So we look at a kind of an anonymized, aggregated level, how users are interacting with the content, how do they tend to sort of access the content, how do they find specific topics, how long do they spend looking at particular areas of our content, and how does their behavior change as we change the design. We also look at qualitative feedback, so things like user interviews with clinicians across the different grades and specialties. What are they using best practice, and what do they think we should do next? So a lot of that's been inspired by the kind of consumer digital app development process from the sort of outside of the healthcare setting, but obviously recognise that as our content becomes more interactive, clinicians are using it as part of a healthcare process in a healthcare system, and that we really need to understand how that interaction behaves and how we're doing performing in that interaction. So we've just started some quality based projects with collaborators using that more QI model of plan, do, study, act, so we can kind of take a more holistic view about how our content's behaving in the wider sort of healthcare setting. And it's too early sort of starting those projects, but it's a really interesting development. Next slide. The other key focuses we have is keeping it current, and that's also kind of interesting from a health informatics point of view. So it's been going now for over 10 years through several different redesigns, but there's a constant stream of new guidelines, evidence reviews, safety alerts, feedback from clinicians. And what we have to do is we have a team of internal information specialists and editors that sift through that. And then they work with a wider body of roughly around 3,000 national and international clinical specialists who contribute to the resource. And between our internal editors and that community, they decide how those changes should be reflected in our recommendations. And then once that's agreed, then that's passed on to our more technical content editors, which take that clinical view and make sure that it's consistently structured in our sort of underlying technical content. And that's kind of interesting from an informatics point of view, because it's going from a spectrum of the clinical side, where you're dealing with sort of senior clinical specialists, and the technical need to be as low as possible. So working word processing, exchange emails, and then the more technical level where we're really trying to aim for this structured content that has to be consistent across the resource. And so there's a kind of a constant interplay between the clinical editors and the technical editors to make sure that that happens. And then to make sure that none of the clinical nuance is lost, we have a kind of a preview platform where the clinicians can then go in and make sure that the platform is actually saying what they intended it to say before it's published live. Next slide. So just to tease out that kind of informatics view a bit more, it kind of matches up with, I guess, some of what the CDS community more widely has been doing in terms of putting frameworks around what all the different kinds of CDS content are. I've taken this kind of 4-level framework, really inspired by a paper by Botswala sort of a number of years ago, talks about 4 levels in this way. So level 1's kind of narrative, and it is around human communication of guidelines. The opportunity for integration into EHR is quite low because those guidelines are live documents. Level 2 is more semi-structured and structured, and there we're breaking out individual recommendations, but it's still about the human communication of those recommendations to clinicians. The integration scope is greater there because the granularity of the content slightly smaller, kind of really where a lot of the BMJ best practice content sits at the moment. The next level is codified, so you're really starting to break apart the content, the clinical concepts within it, using things like SNOMED-CT, and that allows you to then link patient context and the patient data to recommendations and start to filter out the recommendations to particular. And within the best practice product, we're starting to do that with the condition coding and the drug coding that we're doing. And then level 4, which is executable, is the most complex and the most challenging to do. And that's really switching around the purpose from something where a clinician is sort of actively going out themselves and pulling in information as they need it, to making the system the active agent and actually monitoring the patient data and actively putting alerts in front of the clinician as potential to improve patient care. Obviously, integration is then a key sort of underpinning or foundation for that, and usually a lot of that is done within the EHR itself. Okay, next slide. So as I said, BMJ best practice sits at that level 2, pushing into level 3 in some areas, and some background information is in a narrative form. And when best practice was first put together, and it's quite a number of years ago, we had this integration vision. So this is an illustrative patient record system. And the idea would be that you have a patient's problem list, say on the left-hand side. This patient has COPD. Then you imagine a junior clinician, they're about to order some tests, looking at, and they want to, I guess, monitor the patient COPD, and they just want to check that they're not over-ordering, they're not ordering more tests than they need, and they're not missing anything either. So we kind of envisaged an extra CDS tab to that test area of the patient record, where we could pull in that sort of itemized, concise bit of best practice, so that the clinician could just cross-check about their intent decision. Go on to the next slide. We did come across challenges in doing that, and this is a number of years ago, especially in SEC. So the use of these digital problem lists, as perhaps we thought, so that, and if they were there, a lot of the diagnoses were added towards the end of an episode, which wasn't necessarily when a clinician would want to look up information. And there weren't standard EHR APIs in content like best practice. And on our side, really a standard API to express our content to the EHR, which meant it a lot of bespoke work with EHR providers to get this integration working, really scale at that point. So our current approach is a bit more incremental, and it's designed to evolve with the sort of changing picture. So digitization is obviously really accelerating, and it has been for several years now, but we kind of want to provide several different layers of opportunities to integrate from the EHR into best practice. So again, this is just an illustrative patient record system. The first level is really just providing a general link to BMJ best practice at a high level, from the shortcuts links on the EHR or the shortcut icons across the top. The second level, which in the left-hand corner there, is a kind of a search widget. So providing a search API practice that can be triggered directly from the EHR, so that they can stay in the EHR until they find the resource they need. And then the third one is picking up this problem list theme again, but using a standard this time, something called the HL7 Infobutton. So against each item in the problem list, there is a link, and if the clinician clicks that link, they'll be taken through to specific recommendations about the condition. So if you go into the next slide. In terms of the current status and how we're evaluating that current approach, at the moment we've got qualitative feedback, and it's along the lines that the links from the EHR do increase awareness that the information is available, and it does simplify the access to that. And actually, some of that feedback has come outside of England and from equivalent bodies in Scotland, where they've integrated an evidence shortcuts within the InterSystems track care system across different health boards in Scotland. It actually goes to an intermediate page and then on to best practice. But clinicians have fed back that then sort of raises awareness that content is available, and they go and consult that. That's also an approach that's been taken by Leeds teaching hospitals that have added a shortcut link into best practice from the EHR. In terms of the search, which that provides confidence that the answers will be available in the CDS resource before they actually have to leave the EHR. And that's an approach that's been taken by Lincoln and Goole Hospital Trust, and also University Hospitals Birmingham, that have put a search widget with the EHR. We're still really waiting to analyse more data from the sites to get a more detailed analysis of how that's going. But the early sort of initial anecdotal qualitative feedback has been what we have yet is we aren't live in England with any sites using the info button, but we are working with third parties and looking for with them to pilot sites to test that problem list based linkage. And actually we're looking more at the shared care record at the moment to test that out, because it pull in information from several different care settings to maintain that problem list. If you go on to the next slide, it's probably worth me just spending a bit of time talking about what HL7 Infobutton is, because I think it is important to kind of promote the standard possible to do this integration. Is that you click on next to a particular problem and it takes you to the specific page on best practice, providing recommendations for that condition. It's actually a standard from HL7 in the US. It was developed in the 2000s, really as a response to try and simplify the integration approach, while other groups in HL7 did the more complex sort of executable guideline standards, and something a bit more straightforward to start with. And it's got a lot of adoption in the US, forms part of the requirement for meaningful use in the US, which is back US legislation. So both EHR providers and US publishers support the standard. On to the next slide. For those in a more techie detail, it really just at its core is a URL which embeds some anonymized user context as parameter in that URL. So when you click on that COP link, there's a URL with lots of parameters behind it, which basically say things like, please return me a web page. I'm going to send you a SNOMED-CT code. Here's the code and the term. The user's actually reviewing a problem list at the moment. Can you provide some diagnosis information to this user who's a healthcare provider? The patient's female and the patient adult. And it's those last two we're in the process of implementing at the moment, but those other parameters are already there within the best support for Infobutton. If you go to the next slide. Also, for those who are interested or geeks, in terms of driving this from an NHS user point of view, one of the main ways that we see it working is through using SNOMED-CT and the problem list. And what we have to do in the background is tie our chunks of content to SNOMED-CT diagnosis codes. And because the diagnosis in the patient's problem list may be at a different level of granularity, probably more granular than our kind of topic titles, we then use that hierarchy within SNOMED-CT to bridge the difference. So, for example, if a patient had severe COPD, we don't organise our content to have of content on that. What happens is then the info button support goes up the hierarchy until it finds on COPD or a code that's linked to one of our topics, in this case COPD, and then in contrast, for something like an acute exacerbation of COPD, we have a topic directly linked to that. So if the patient had that as a problem and the clinician wanted information on that, we'd directly return that. I guess the other thing to note is SNOMED-CT is there's lots of different hierarchies, and we have to be aware that some things sit in different hierarchies. So there's a situation hierarchy in there, and things like suspected COPD sit in that situation hierarchy rather than the disorder disease. So we have to be aware of those codes as well and recognise those. Go to the next slide. So in terms of evaluation of InfoButton, it's too early for us to kind of present our own evaluation based on our InfoButton, but because it's been used in the US for a fair number of years, there are both a significant number of studies and now reviews of those studies. So this is one by Cook and et al. And it looked at 17 relevant studies across US institutions. Usage was between 0.3 and 7.4 per user per month. Used most often during prescribing and lab ordering tasks. It was actually used less often than the more general links that I was talking about before, but when they did use them, it was found to answer questions 2/3 of the time, and it changed a clinical decision so anywhere between 50 and 91% of cases. There's large variation there, and I think it's due to the different study designs underlying this. The time to answer a question was 25 to 97 seconds across the studies, but no studies directly assessed the clinical impact of this, and they basically concluded that more evaluation needed to be done. So we go on to the next slide. So as well as kind of pressing on evaluation, sort of ever more evaluation, we also have to keep track of the kind of the changing technical landscape, both in terms of things like the AI technology that's coming through, but also some of the new technical standards that are coming through. And I'm just going to quickly touch on two, which are interesting. They're both linked again to HL7. It's called Smart on Fire, which you may have come across. And profile launch an app from within the EHR. And it uses the richer HL7 Fire standard as the way of exchanging data and actually go two-way between the app and the EHR. It's not actually constrained or specific to clinical decision support. And actually this example in the left-hand side of is from their showcase, and it's a cardiac risk app, and it's really about providing different data visualizations of the patient data, overlaying in this case a cardiac risk score on that patient data. Kind of relies on the clinician manually launching the app, and that's seen in some CDS situations as a bit of a limitation. So there's another related standard that's gaining maturity now called CDS hooks, and that actually provides EHR triggers, things around like prescribing and ordering a test that invoke external CDS services and provide in a kind of secure environment package of patient data to analyze that decision. And then an answer comes back as a set of concise summary cards, which kind of provide suggestions about potential areas about improving the care, potentially alternative decisions with links to more information if available. I think those two standards are really interesting, and actually we're currently on the Smart on Fire Advisory Committee. But it's interesting that I'm not aware of much discussion in the UK about those two standards. And the last slide. So for me, I mean, in summary, I think there's a need to maintain a human focus to the CD content, because obviously it's a human clinician that's consuming it at the end, and that's also true for integration. It's really a human clinician that's using the EHR and trying to access CDS content from integrated within it. Obviously, there's constant need to evaluate how clinicians are interacting with it and how they behave, as both the design of the EHR and the clinical decision support and the content changes. I think the community should take advantage of the standards that are both available now and are emerging to try and reduce some of those technical barriers to integration and achieve a kind of a scale of different implements. Okay, so thanks. So if you have any, hand it back to Nick.
Well, thanks, Chris, and thanks for a really detailed and fabulously clear presentation, which I thought was terrific from both of you. Got one or two questions coming already. I wonder if invite people to comment on their questions. Andy Webster from Leeds Teaching Hospitals made a comment that his integration is currently out of the EHR landings to the landing site. So that's a fairly limited implementation, but it shows that he's a user. I wonder, Andy, if you'd like to comment about the experience of using it in your trust.
Yeah, hi. Yeah, one of the TCOs in these teaching hospitals. It's one of the things we put URL in, but we haven't got any data being used at all. Unfortunately, because it would give. We also did have UpToDate before repurchased UpToDate again due as a result of COVID. But we haven't got any integration with UpToDate in the EHR at all. There's no launch site, but we can actually get some. You can use the statistics for the. We can get user statistics for UpToDate. I think when we looked at it before, it's costing. When we had it before, it's costing about £10 per website lookup, which is why I made the decision to stop it in the first place. So it'd be interesting to know.
Andy, would either of the presenters like to comment on that?
I mean, I could certainly take away the if there's anything we can do on our side to feedback usage information that we haven't look at that and how because I think the idea with this that we kind of set up some tracking information on those links that come from the EHR so that we can pull out how many coming our link. So I can take that away as an action.
Okay, thank you. Andy and also Vered Frechter commented that there is an issue with alert fatigue, which I think you touched on, Chris, but have you got anything more to say about alert fatigue? I remember when I researched on Prodigy decision support, probably about 20 years ago, actually, that was one of the major problems about our implementation. The alert fatigue was almost comprehensive, and a lot of people just stopped using the system because it interrupted them.
Yeah, I think I guess that's why we've kind of been slightly reluctant to dive into that more executable level, because it relies on a lot of background data to make sure that the alerts that are provided are completely appropriate to that situation. So at the moment, a lot of what we do is based on the other model where the clinician is explicitly going out to pull in recommendations as they need them, rather than trying to push recommendations at them.
Thank you. We've got a couple of comments and questions from our chair, Jonathan Kay, to do with decision support for results and investigations. Jonathan, would you like to say something about that? Possibly unmute, Jonathan. Okay.
Yeah.
Well.
Yeah, thank you. Yeah, Chris, a really nice presentation. Thank you very much. You spotted this point about decision support at the point of requesting investigations, as well as that big analysis. We've got an NHS health technology assessment that does suggest there's value there. We think it's all very high for acceptability. You didn't mention management of incoming reports for investigations. I think those two together are one of the real targets for reducing burden on staff, with comparatively simple rules compared to the other some going on. Now, we've linked to EHRs, but in fact, the request report process really isn't carried out in it's carried out in a rather more complex setting, perhaps for historical reasons. And I wonder if you see that as a sweet spot over the next few years.
Yeah, that's really useful feedback. It's something that I don't think we make enough of within our content. So we do have a lot of investigative information and recommendations, but we haven't really pulled that out as a distinct part as much as we could. And also, yes, I guess integrating not only with the EHR but also with the kind of more lab systems, which are looking to, for sources of clinical decision support content.
I've got a question, Christopher Weatherburn. Could Christopher unmute and tell us his question?
Yes, thank you all very much. It was about the URL code, which had, I believe, gender and other demographics like age. I wonder, does that have prescribing information attached to it? Because a lot of the time, as colleagues have alluded to with decision support, you eventually get round to prescribing something, and then there's so many different warnings that come up. But if these bits of best practice are shown when perhaps somebody is doing something that would be either not recommended or a preferred treatment option would be more strongly recommended, would there be any way of incorporating that? So basically, is prescribing data being looked at through that? And thanks for the great presentation.
So, in terms of the existing implementation of the info button, it's much more conditional. Both the standard for the info button supports transmitting more information around drugs. It's not just supposed to be condition focused. And also from our side, we've done, we actually, our most structured part of the content is our kind of treatment options, and the coding around that is actually the part where we spend most effort. So there are opportunities there to look at that. And as like part of the ongoing product development, something we would like to do. We also, as an organisation, we co-publish the BNF with the Royal Pharmaceutical Society. So that is also kind of something we'd like to explore.
Thanks very much, Christopher.
Nick, Philip Scott has just sent some questions through by email because it looks like he's unable to use chat. So Philip, I don't know if you're able to unmute yourself and ask your questions.
Yeah, thanks, Joe. Yeah, I don't know where my chat's gone. Yeah, two questions, Chris. First of all, great presentation. Thank you. So you talked about link to BNF coding. Is there any recognition of DM&D coding?
So we actually linked to DM&D for a number of years ourselves. To drive that BNF link, we actually use the internal topic identifiers for the BNF, and then within the BNF data, we don't do it at the moment, but you could then go from that because they provide information about all that link to their drug topics. So the route through that, yeah. Okay,
thank you. And my second question is whether best practice is regulated as a medical device.
Yeah, so it's a question we get asked a lot, and actually, so it's kind of under constant review. So we have a clinical director within the BMJ, and we have contact with MHRA as we develop new aspects of best practice to get advice about where we sit on the borderline between the content as a source of recommendations. Class 1 software as a medical device. At the moment, it's not considered a Class 1 software as a medical device, but as it becomes more interactive, we're constantly reviewing that to make sure we are kind of taking the appropriate steps. And also, it's worth, I guess, we also have some of the things that would be required as being a manufacturer of a Class 1 medical device, we do already do. So we have a kind of an internal clinical safety process that constantly sort of manages or monitors for incidents and looks for hazards and follows the kind of agreed standards for clinical safety management.
Thanks very much.
Our question as well, actually. The precise definition of decision support and how it's separate from AI or artificial intelligence. Just going around the place and talking to clinicians in various parts of, the medical NHS, there seems to be quite a lot of confusion about what decision support is, and it does in fact range the kind of things that you've been talking about. And in fact, you listed 3 specific products which you felt were in competition with one another. 2 other things which do entirely different things, maybe contactly from the electronic health record and maybe as standalone devices. And I think it might be beneficial to be more specific about this. I mean, I'm talking to people in the northeast of England. Many are unaware of the availability of the BMJ resource, and I wonder if a particular trust wants to take up BMJ Best Evidence and integrate it very tightly with problem list or other features, info buttons, whether it costs anything extra or whether that's all borne by the contract with Health Education England. So it's a bit of a compound question. Maybe Lucy can say something first and then Chris second.
Would you want me to go? I guess those kind of that incremental thing going up to HL7 Infobutton is included as part of the funding from Health Education England. So there's no charge from us to do that level of integration. Although when we're talking to trust, if there are any changes that are required on the EHR, that's where sometimes sort of project costs or kind of change note costs come in from the EHR vendor to kind of switch that functionality on or do anything on their side. So that's the and the second one about clinical decision support is definitely, it is a grey area. And I guess having come from a slightly so I haven't come from the kind of medical publishing or library science side of things, and so I've come from the active clinical support and rule-based area. I sometimes have difficulty myself trying to square the various different definitions that are floating around for what is clinical decision support, and so the best way I do it is by just trying to provide examples of what all the different products or sort of use cases provide.
Yeah, well, thank you.
Echo that we used to call this point of care, and now that was a conflict with people's understanding. So we use clinical decision support now, but there are also things like clinical key. People think that's clinical decision support, but it's a very different product. So there isn't really a language that's common around this. And like Chris, we tend to go the thing that does these things.
Okay, well, we're coming to the end of our time, and I think we've had an absolutely splendid session here. So Thank you both for very well prepared and comprehensive presentations. Forget everybody that you can watch it again on the YouTube channel, which you can access via the Faculty of Clinical Informatics website, and that there will also be an evaluation questionnaire being sent out by Joe, which I think everybody would love to see. Sorry, we would love to see everybody completing. Sorry, and with that, I think it's probably time to finish the meeting. Would you like to say anything in conclusion, Joe?
No, that's everything. Just want to say thanks to Lucy and to Chris, and I've just popped the link for the webinars, the video posted afterwards.
Brilliant. Well, thanks very much indeed.
Thanks, everybody.
Thank you.
Thanks.
Thank you.